how we are going to provide dental treatment for our patients. And this came from a recent article from the British Journal of Oral and Maxillofacial Surgery, where it shows what a minimum change we will need to have in our offices as well as in a hospital setting. Now, it can get as dramatic as this, where we are trying to protect not only our staff and our patients, but ourselves. And so you can imagine trying to perform complex, delicate procedures like we're all trying to perform. And so how do we overcome those restrictions that these required PPEs will have on our ability to provide ideal surgical care? So again, I refer to this article that was just published a month and a half ago, where we are faced with differences. As healthcare professionals, we are playing new roles, not only as police officers for controlling our offices, but in the hospital setting, we're called upon to play other roles as well. And that introduces the human factors and non-technical skills that each of us have to overcome. And then finally, the use of PPE and how does that affect us physically and psychologically, as far as knowing which forms of PPE we should be using on a daily basis. Another article from the journal Cranial Maxillofacial Surgery, where the statement was made that influence of COVID-19 pandemic on the delivery of healthcare to the public is severe. And the conclusion in this article, in order to address the challenges adequately, significant changes in the infrastructure of outpatient units, inpatient units, and operating rooms are needed. In addition, the demands concerning personal protective equipment have increased significantly. The major aim is to protect patients as well as medical team from unnecessary infection and to keep the healthcare system running effectively. Therefore, every effort should be taken to make the necessary investments. And it is truly a major investment, not only of monetary value, but of our time and efforts. And so how does the digital technology that we're dealing with today help us with the transitioning from freehand, which I call analog, to guided to navigational surgery? We are all aware of how to perform our implant procedures, basically freehand, but how many of us are now transitioning into a computer-guided approach where we are performing static guided surgery, and how many of us are now transitioning into dynamic navigational surgery? So achieving successful osseointegration with freehand surgery, we all are aware of what is needed. But again, this is analog implant dentistry. So with that, what I have done is listed some of the benefits and risks associated with analog freehand surgery. It's simple to get started, but it generates significant aerosol and with most steps. And this is the risk that we have to control in this era of COVID-19. It's a proven surgical method, and we all understand it requires three-dimensional placement. The surgical skills are easily learned, especially with this group, but we have to have additional skills when we're faced with deficient tissues. It provides us with moderate flexibility, but it only comes with the various prosthetic components. And that is because these are the situations where problems do arise. When we have short mesial distal length, the inexperienced surgeon tries to squeeze in too many implants, and you end up results like this. Where there's lack of vertical bone volume and lack of alveolar contours, you create dehiscence and fenestration defects that ultimately will affect long-term success of these implants. We fail to identify poor gingival biotype, and we end up seeing significant aesthetic issues, such as you see here. And with improper three-dimensional implant placements, we have every single type available that you can imagine coming through the university. And finally, close proximity to vital anatomic structures. And so, you know, to overcome all these issues, we have moved into the digital evolution where many of us have transitioned into static guided surgery. And is this the answer or a panacea to all of the issues? Probably not. We understand the need or the workflow of the digital approach, where we go through the normal evaluations and determinations of whether a patient may have fixed restorations or require a removable prosthesis for lip support. But as you can see here, all of this is generated from a CAD/CAM image, and so there is no aerosol being generated. And once we have the digital images transferred onto the software program, we are able to plan and truly have this planning restoratively driven so that we are placing implants in the ideal locations that are dictated by the location of the restorations. And again, these are all digitally generated, therefore there are no aerosols that are being created with our surgical template, as you can see on the upper left, as well as the provisional and definitive restorations. So this is really the only potential step where we are generating aerosols. But the beauty of this is that you can elect to go without reflecting soft tissue flaps. And the only aerosol generation would be with the irrigation solution. The key factors in getting ideal results with the guided static approach is the placement of this surgical template in the ideal location three-dimensionally. And the three dimensions that we need to control when we're placing the surgical template is the roll, pitch, and yaw, similar to flying an airplane. The roll addresses the level of the position of this surgical template, that is left to right. The pitch is front to back tilt, and then the yaw is that midline rotation left to right. But when it's all said and done and it's performed properly, you can get significant improvements in the results of the treatment that you can achieve. And again, all digitally generated so that we can ideally position these implants in the right, now four-dimensional positions. And by performing this method, we are able to generate some truly highly aesthetic clinical results that saves us a lot of time as well, because now with each crown generated for this framework, if a crown chips or breaks, we do not have to remove the entire framework, just removing the crown. And we, within a day, have a replacement made for it. If we have to remove the prosthesis or the entire framework, we know exactly where the access openings are. Therefore, we don't have to really destroy the entire framework in trying to get it off. And so again, by taking a digital approach, we can effectively provide our patients with an aesthetic definitive prosthesis. And we are showing extremely long-term successful results with these approaches. Here is this patient 7 years post delivery of her definitive prosthesis. And you can see that the bone levels have been maintained throughout the maxillary arch. Now, moving forward with controlling the aerosol, we have started to perform our workups without having to take analog impressions or, for that matter, intraoral radiographs. And I published this article with Alessandro Pazzi a couple of years ago on the smiling scan technique, where our patients, when the double scan is taken, are put in a full smile when the x-ray is being done, so that we can directly transfer that image onto the software program, allowing us to see where the patient's prosthesis sits in relationship to the ridge, as well as to the soft tissue contours. And so we are able then to plan out our positioning of implants in the ideal locations to support a fixed prosthesis that will allow us to provide the necessary lip support, but also placing it in the ideal osseous locations. So with static guided surgery, the take-home message really is that, again, risks versus benefits. We see that the planning programs are open platform, but there is a steep learning curve with the planning program. So we need to train ourselves to be watchful for some of these issues that can occur. It's a well-tested surgical method. I've been performing static guided surgeries for close to 20 years now. But the planning does require four-dimensional placement or visualization. So we have to add a fourth dimension, which is what I call the arch position, which addresses the tilt of these implants, not buccolingual or buccopalatal, but the tilt of these implants based on the needs of the planned restoration. Surgical skills are easily learned because we're drilling through a guided template, but we have to have, again, additional skills when the cases become more complex, typically where there is soft and or hard tissue deficiencies. It's a high degree of accuracy, but there's no flexibility intraoperatively. And again, intraoperatively, surgically, it does generate a moderate amount of aerosol. So this is why moving into a dynamic guided situation for me is the preferred route if we're trying to control the spread of the COVID-19 disease. And again, taking a digital approach, we are able to control the positioning of the implant, both from a mesial distal standpoint. Here you're seeing how I'm moving this buccolingually to improve the tilt. And now I'm addressing the mesial distal direction. And what you're seeing in the middle screen there is the moving of the apical coronal position of the implants. And so we're controlling the implant positions in our digital workup and diagnostics rather than in the patient's mouth itself. And what you're seeing on the top screen is a fifth dimension that I will show in a minute what I'm talking about. So when we use dynamic navigation surgery, it allows us to get tremendous results as long as we have careful and accurate planning. This all comes down to the ability of the surgeon not to perform the surgery, but to perform accurate planning. And as you can see with dynamic navigation, we have control of all 5 dimensions. Now, what are those 5 dimensions that we're talking about? Well, first and foremost, we need to be able to see the volume of soft tissue in relationship to the hard tissues. And that is where dynamic navigation really shines, because it's very easy to take the STL files from the soft tissue scan and stitch that onto the DICOM files of the hard tissue. And with this view, we're able to see and determine the 5 dimensions that we need to position our implants in. That is the mesial distal position, buccal palatal or lingual, apical coronal or depth. As I mentioned, the arch position or trajectory of that implant. And finally, the cone position, which I learned from the use of dynamic navigation. Here you can see where the views from the planning program allows us to determine these 5 dimensions. In the mesial distal position, I use, again, the 3-dimensional view to allow me to position that implant ideally in the middle of the mesial distal edentulous space. Buccal palatal or lingual to adjust the angulation of that implant to maintain the necessary required measurements of thickness of bone. As you can see on the buccal aspect, we have almost 3 millimeters. Each of those marginal lines indicate 1.5 millimeters. So you see we have, by positioning this implant slightly to the palatal, we have maintained almost 3 millimeters of labial bone thickness. The apical coronal, again, allows us to control the distance from the neck of that implant to the prosthesis or underneath the soft tissues. And again, typically we teach our residents to place the implants approximately 1.5 millimeters below the crest of the alveolar bone. Arch position is really, again, the trajectory that the implant must go. And as you can see in this position of the canines, there's a slight flare out to the labial. And finally, the cone position, as you will see in the next slide, what I'm focused on during surgery is this circle. And now that circle indicates really the tip of the drill. It does not indicate the length of the drill. However, intraoperatively, you will see how we control the length of that drill. So here you can see we're starting our procedure on this patient, and this is the screen that I see on dynamic navigation. You'll see that the key for me is in that top left screen, the angle. You see that the drill is bouncing all around, and that is because I'm trying to get through the dense cortical bone. Once I am through, and you can see as far as the depth is concerned, you'll see this green circle, or yellow rather, show up. And so you see there, I'm getting to about 3 millimeters depth, and I'm still trying to, get through very dense bone. Now, as we get deeper, what you're seeing is the angle of deviation we're trying to keep below 1 degree. As you're seeing the angles flaring out, what you're really seeing is a whipping action, as you can see with the twist drill extended on the handpiece. There is a degree of whipping that occurs the longer those drills are. However, when I get to depth, typically, again, we try to get that angle of deviation up below 1 degree, as you can see right there. The results can be spectacular, and it's not due to surgical skills, but to the surgical planning as far as positioning. You can see here a very tight mesial distal spacing, not at the coronal portion, but at the apical portion. And so when you have divergent or convergent roots rather, you need to be spot on as far as the position of the implant. Otherwise, you're going to get dental integration, dentinal integration with the root surface. And again, the results can be spectacular, not from a surgical perspective, but from a prosthetic perspective. And it requires a interdisciplinary approach where you're working with restorative doctors, prosthetic prosthodontists, that allows you to manage the soft tissues, as you can see here. Within 1 week, a black triangle fills in very rapidly if you handle the soft tissues properly. And so with the management using navigational dynamic implant surgery, we're able to achieve really spectacular aesthetic results. So what we're seeing as far as benefits and risks, the earlier skills learning with freehand surgery as well as static guided surgery, it's easier to learn navigation, but it still requires us old fogies to learn new techniques. We have to observe 5-dimensional positioning in real time, but we need to plan for those 4th and 5th dimensions, and we need to be aware of those. We can easily manage more difficult clinical situations, such as placement of implants into converging root tips, but we have to have the skills to manage those difficult situations. It gives us full flexibility, and there's flexibility during surgery, but you have to have accurate planning. And finally, navigation surgery, to me, minimizes generation of aerosol and trauma from surgery. So with that, I'd like to conclude that it is a fantastic time to be involved in implant dentistry, and especially in the era of COVID-19. Thank you.
Thank you very much, Peter, for an absolutely fascinating lecture where you combine precise planning and the history of that planning to which stations we went with patient safety, practitioner safety, and creating less aerosol. Alvin, you're the administrator. Did you get any questions?
No, there's currently no questions.
Right. Can I kick off with one?
I have a question. I have a question.
Yeah, go ahead.
I'm not without using the chat. Peter, are you familiar with the Da Vinci?
Yes.
Can that be the next stage of development with this navigational approach?
It's
Where you
already,
actually, and then you're totally removed from the whole aerosol environment.
yeah, it's already there. You know, in China 2 years ago, they did the first robotic surgery. And we haven't heard much from the school. I'm actually a visiting professor there, and they've run into certain complications. The beauty of Da Vinci is that we can use it with, a patient that is static, laying flat. With our patients, unless you put them to sleep, they're awake, they're moving. And so it's important to hold that head very, very still. And so that is the issue that we're trying to work out right now. Unless we put them in a head frame like we used to do with Lefort 3 fractures, it's difficult to get these patients to maintain stability, and therefore allowing the robot to, do its guided surgery. So
Mhm.
Yes, I'm very familiar with it, and we are working on that.
Thank you.
Any other question? The floor is open.
Peter, would
Yes.
you please explain again what you mean with cone position?
Yes, it's very simple. If I have let me get a pen first. My residents have a very difficult time viewing this. All right. So you're trying to get a implant into a position, right? In one dimension, this is vertical, this is occlusal. So your aiming point is in the center of that circle, right? Depending on the diameter of the implant, it could be 4 millimeters diameter, but the apex is typically 2.8, 3.0. And so the tip of the drill has to match the tip of the implant. Now, if you turn it straight up, what happens is as you're going down, how many of us can go straight down without using a robot? The robot can do that, but a human cannot, even with dynamic navigation, as you can see, that whipping action from the angle of deviation. And so as we get deeper and deeper, what happens is the human trait is to go like this, right?
Yes.
What happens there is it changes the angle of the drill to doing this. And so your apical portion can still be at the aiming point, but now your drill has created an opening that is wider than the 4 millimeter. And so therefore, picture the implant going down into a cone. The stability of that implant, the accuracy of that implant is really dependent on the crestal preparation site. And the more whipping that you have, the wider that diameter becomes and the less accurate the implant position. Does that make sense?
Yes, thank you.
Like an ice cream cone.
Ice cream cone, yes.
Yes, like an ice cream cone, basically.
All right.
Any other questions?
May I ask a question?
Sure, go ahead.
If I can answer it, yes. Go ahead.
Sure. Talking about accuracy, you are using a navigation system and we are talking about a tenth of millimeters. Did you ever control the technical accuracy of your navigation system? And can you give us some numbers about the deviations you observe? It's a cone side and it's a top side.
Yes.
Of the implant.
Excellent question. And the answer is yes, I have. I have gone back and reviewed the accuracy of dynamic navigation. And Franz Joseph, with that, it really is dependent on the surgeon.
Okay.
We've done the same analysis with static guide. And with static guide, the deviation can be significant simply because the static template was placed in the wrong position. Okay. And so dynamic navigation, however, we can get down to as accurate as 0.05 millimeters, depending on the surgeon's abilities.
Okay.
And so again, when it comes to accuracy, this is why I say that we have to learn a new skill. It's all over the map, but it's not due to the computer, the program, or the instruments. It's due to the surgeon.
Okay. Thanks.
What a question.
I have a question, if I may.
Sure, go ahead.
Is there, so to me, it seems with I've not used navigation, but I'm interested in it, and I don't do a lot of guided, but what about the combination of the two? Like, I think if your entry point is probably the most difficult thing with guided, with the navigated surgery.
Yeah.
And if you use the navigation to kind of ensure that your starting point is accurate.
Yeah.
It seems
Yeah.
like you'd then be able to get started a little easier.
You would be able to combine the two. However, from a cost standpoint and from a time standpoint in surgery, no one's going to do that. All right. But you can, yes.
I have a question for you, Peter. Has the fact that you have that cone presented on one of your screens, where we could read on your video the deviation in angles from the ideal direction, does that feedback over time teach you to be more precise and to have less of that human flexion tendency of the human wrist? Or is it every time again a question of getting deep enough into the bone to get more precision, as the walls of the cavity basically keep you in a better direction? And it is much more the tactile feeling and the depth that control your deviation than the visual feedback you see on the screen. What is your perception there?
My perception, and this is from watching residents using the navigation, where I start them off with freehand and watch how they improve with navigation. And it absolutely teaches them a better technique as far as avoiding the flexion of the wrist.
Yeah.
So it's a great training tool as well.
Yeah. What kind of system do you use for your navigation?
I thought this was non-commercial.
Okay, that's
I
clear.
use the XNav.
XNav.
Yes.
Tim,
Okay.
you had a question.
Yes,
Go
Nick.
ahead.
Thank you. I was interested in the comments from Professor Feinberg and Moy about trying to keep the head still for robotic work. At the Christie, with the Proton Beam Center, we've been working on printed splints to hold the jaw and the tongue in the correct position and spare radiation to the mandible. And now we're moving on to try and get away from the masks. They make a mold of the patient, they pin them to literally screw them to the table whilst they fire the radiation at them. And we're looking at trying to create a printed mold with projections which can connect to a framework. So the patient feels less claustrophobic without the mask, but they're actually held in position. And we're really at the thinking stage at the moment about how to monitor whether they are actually staying in the position or not. But because of course the oncologists are nervous that if they rely on that as a new system, they want to be able to test that the patient hasn't in fact moved. So they're discussing either using a laser scan on the face, as we use in skull-based surgery for stereotactic navigation, or putting the old-fashioned skin fiducial ring stuck on the skin and using that as a trial. I just wondered if that was an area that you had gone to in your thinking, whether this may be feasible and acceptable to patients in the office setting, or whether you think they would be too claustrophobic and feel they are fixed into your chair while you're drilling their head.
And that's exactly right, Tim. We have looked at it and we have attempted to try it. And I would say it's regional. In other words, and I don't want to be profiling, but in China, it's very easy to secure them that way and prevent them from moving. However, in the US, there is no way. There is no way, especially with patients who are claustrophobic. I just had one yesterday that refused to have a mat or face cover during surgery. So can you imagine putting one of these retainers on? I would lose a patient.
Yeah, I guess if they're having treatment for cancer, it's rather different to this, unless a better, smarter solution can be found. I don't know.
Yeah, definitely there is a better solution, but we just haven't pinpointed yet.
It's almost analogous to wearing a mask. You can wear it in Asia, but you can't wear it in US. It affects your freedoms.
Although we're learning.
Any other question for Peter?
I have one more question about the Da Vinci.
Yes, Jason.
So I'm only aware of the Da Vinci for, prostatectomies and things like that, robotic surgery. Is that the same machine we're talking about?
It is.
So
Cardiac also. Does cardiac surgery too.
yes. I'm sure it has
Everything else. No.
It does a lot of other things. Yeah. So is this still controlled by the surgeon, or is this you're inferring that maybe a robot could do the entire procedure?
Correct.
By programming.
Currently, it's controlled by the surgeon, but we are looking at programming that allows the robot to take the information directly from the plan and apply that in surgery. So the surgeon doesn't necessarily have to be there as long as the plan is done, which is why I mentioned it's most critical to have an accurate plan. And so, from a futuristic standpoint, we will be determined as are great surgeons based on planning, not what we do with our hands.
It is interesting because people are also working on much smaller robots. Trials have been done with the Da Vinci in cleft palate repair and pharyngoplasties and speech surgery. And although there have been benefits of using it in apparently oncology of the rhinopharynx for cleft palate repair, also because it extends further anteriorly, the machines were too big and there was no real benefit. The time took much longer, it was much more expensive. It's a controversial tool, as it is expensive, slows down surgery, and in particular for that specific type of surgery, there was no real benefit. I imagine for anterior dentition, it might be helpful, but I think with the introduction of smaller robots, and as we all know, machine learning is developing at a tremendous speed, I think there is a very good chance that Peter will be on the golf course while his robot does the surgery for him.
Why do you pick
Any other, sorry?
Why do you say just Peter?
Any other question for Peter? No? Peter, once again, thank you very, very much. Most interesting, fascinating, also with that window on the future. Yes, I think we are allowed to applaud, Henrik.
Thank you.
Even virtually.